reminded me in the coffee break, it's just a lesson in patience. So we might have our patience a little bit tested, but we'll do our best. We've got an hour of talks by 3 wonderful speakers who I'll introduce in a moment, followed by 30 minutes of Q&A and then lunch. So we are conscious that we'll be keeping everybody from lunch, so we're going to try and stick to time. I'm going to be very strict, the speakers already know, with 5-minute and 2-minute warnings. And then we have a Q&A session where I would like to encourage particularly our female and our young scientists to ask questions. I'll be taking questions from the audience as well as from online, as well as from the app, and that's because I note that a lot of our young Gambian students are very active on the app, so if you don't feel comfortable enough asking a question, you can write it on the app, and I will be looking for questions on there. Also, if you can't hear the speakers, please wave your hand or something. We've got wonderful presentations. We want to make sure you can hear them. So that brings me on to introducing our first speaker, who is Professor Kara Hansen, Professor of Health Systems Economics at the London School of Hygiene and Tropical Medicine, with over 30 years of experience researching economics of health systems in low and middle income countries. Actually, Professor Kara Hansen doesn't really need an introduction because we all know her and her wonderful work. But just to briefly say that she recently chaired the Lancet Global Health Commission on Financing Primary Healthcare and has authored many, many publications and led many studies. So with that, I'd like to invite Professor Hansen to give our first presentation. Thank you. Thank you.
Super. So thank you again to the organizers for this wonderful opportunity to join this excellent conference and to celebrate the 75th anniversary. What I'm going to do is outlined here, so I'm going to talk a little bit about what I mean by health policy and systems research, a little bit about some of the frameworks that are commonly used, and then I'm going to just give you a sneak preview into a new report from the Alliance for Health Policy and Systems Research that is proposing a new way of thinking about health systems that I think will resonate with many of the topics we've discussed here at this conference. And then I'll move on to some of the challenges of our work in Africa and beyond. So this definition is taken from the Alliance for Health Policy and Systems Research, which is hosted at the WHO in Geneva, and is really an amazing set of individuals and resources for health systems research. And I've highlighted what I think are the really important elements of the definition. It's research that seeks to understand and improve how we organize ourselves to achieve our collective health goals. But also, it's also about actors and about how actors interact in the policy process, but in the implementation process as well to contribute to successful outcomes. It is interdisciplinary. You'll have heard that I'm an economist, but there are many, many disciplines involved in health systems research. And we also like to look both at how health systems respond and adapt to policies, but at how policies can in turn shape health systems and the broader determinants of health. And I kind of like to think about the field as reflecting both research on some of the generic health systems elements, things about financing and human resources and governance of health systems kind of in aggregate. But perhaps most relevant here that it's also about understanding how disease-specific interventions operate in a health system context and what sorts of changes to the health system context are needed to deliver these interventions effectively. And just to give you a sense of some of these issues, just that I've picked up over the last while, we talk about let me go on, I'll come back to that in a moment. So some of you will be familiar with what's known as the WHO Health Systems Framework, and the building blocks are there on the left-hand side. We talk about service delivery and health workforce and information, etc. But I think it's also a system that is complex in many ways. It's a way of identifying the essential features and the relationships among them. And it also, they can be descriptive, or they can be explanatory, or they can be normative. So you can see actually if you look over onto the right hand, most practically they're useful for organizing our ideas, for identifying these relationships, and also focusing our attention. And often people who are new to health systems research will say, well, what framework should I use? And so there's a lot of other frameworks to choose from. Let me give you a sense of some of them. So some frameworks look at subsystems. So my area of focus for the last couple of years has been the health financing subsystem, which looks at the way that resources are generated for health, the way they're pooled to allow cross-subsidy, the way they're used to purchase services from healthcare providers, and how that affects health service provision. And so in the Lancet Commission that Julie just mentioned, this is the Lancet Global Health Commission on financing primary health care, we took that health system framework and adapted it a little bit by including at the base of it the importance of the political economy. So looking at the political and social and economic factors that can enable or constrain financing reforms. And across that bottom in the right-hand corner, this is one of the messages of the Commission is how the sources of financing of primary health care change as countries get richer. And you can see how that green bar at the bottom, which is out-of-pocket payments, as countries move from low income through to lower middle, upper middle, and high income, that share of financing for PHC that comes from out-of-pocket payments reduces in favor of increasing government commitments. But there's lots of other frameworks as well. I quite like this one on the left that distinguishes the hardware of health systems, the equipment and the people and the drugs, from some of the software, which it looks at knowledge and skills, at systems and at processes, and also at the very top, some of the intangible software, these relationships of power and norms that influence how health system actors behave. The middle framework is one that comes from colleagues at Harvard. It's known as the control knobs framework, and it focused particularly on the things that you can adjust in systems around regulation and organization and financing. And the one on the very right that's kind of the latest in health systems analysis, is to recognize that health systems are complex, adaptive, and dynamic systems that are characterized by feedback loops that affect not just actors affecting each other, but also actors affecting themselves in terms of feedback, that can create a sense of path dependence and unintended consequences. So it opens our mind to the fact that just because we're intervening in a system doesn't mean the system is going to respond the way that we expect it to all the time. So health systems thinking continues to advance in face of new challenges. We heard yesterday some fantastic research from Modu about the problems of non-communicable diseases, which require not just health services, but health prevention and promotion. They make different demands on health workers and patients, and also for which we're really going to need interventions that go along the health system. Bai Cham, who I think is away studying but was based here at the unit for some time, was part of a GCRF project that worked on tobacco policies. Obviously tobacco with really important influences on health, but for which the most important intervention, taxation, lies outside the health sector. That's something that ministries of finance generally decide on. We heard from Chris about climate change and health. Well, it's really clear that many factors from outside the health sector are going to impact health. And what that means is that we have to move really our thinking beyond the idea of health care systems to systems for health. So this report that was published last week from the Alliance proposes a kind of a broadening of the way that we think about health systems, particularly driven by the needs to address the challenges of healthy populations, but also of health security. And it argues that all the existing ways of thinking of health systems tend to neglect these four areas. So one is the importance of trust and power. The second is the need to involve communities. The third is the need to engage beyond the health sector. And the fourth is the need to engage beyond national boundaries for health. So when we think about what the future of health system research should look like, we have this dual challenge, right? We haven't solved the old problems of the care systems. We know that coverage of essential interventions remains suboptimal, and there's also lots of problems of quality in healthcare systems. And so we have these kind of old problems that health systems research is still trying to grapple with. But we have a whole set of new challenges that I think speak to this broadening notion of what the health system or what a system for health might look like. So what I thought I'd do in the rest of my talk is to give you some kind of highlights of the sorts of really interesting areas of health system research where there's good work ongoing at the moment, in a way to kind of inspire you to think differently about systems for health. So I'm going to talk a little bit about corruption, I'm going to talk about taxation, I'm going to talk about digital technologies, and about the regulation of e-pharmacy. I was going to start by saying something about listening to and hearing community voices, but actually Deborah's presentation in the earlier session spoke to that incredibly well. I guess the one thing that I would add to her discussion of different models of co-production and community involvement is first of all that it requires really new capacities, and not just the capacities of the community to engage in this work, but also the capacities of researchers to engage in this work. If we're going to be really meaningfully engaging communities, and by communities I mean affected patients, community groups, health workers, decision makers, if we're really going to engage them, then we need in the parts of research throughout the whole chain, then they need to think differently as well. And I think, importantly, it probably requires a bit of humility, because this is a change in the balance of power in research relationships, and it involves recognizing that not all expertise lies with the scientists. I'm going to go through a couple of other examples. So one of them is corruption. So corruption is such an interesting topic, isn't it? It's something that we know affects our health systems, but is very rarely spoken about. And that's for a couple of reasons. One is that it's hard to define. So I'm going to use the term corruption to mean the abuse of position for private gain. But also, we don't like to talk about corruption because sometimes we have a sense that corruption is what enables dysfunctional health systems to serve the needs of their users. So, for example, if you think about boundary levels of corruption, we're familiar with procurement corruption and the sort of backhanders that go with big infrastructure developments. But if you think about things like widespread absenteeism of health workers, or if you think about the informal payments that go on between patients and health workers, whether they are demanded or whether they're offered, they sit in that fuzzy boundary of corruption and yet pose great challenges to health systems and often are there to lubricate systems that aren't working all that well. We also don't know much about corruption because it's hard to research and risky to research. So I think people may be familiar with the threats to the Nigerian director of the pharmaceutical agency, who actually was the subject of not just death threats, but death attempts while she was in office. And I think researchers are wary of the topic because of the threats that it poses to them. And we also, to be honest, don't really know much about what works to address corruption. So it's an area that's really rife for more research to identify interventions that might work and to test them out. This area of research also requires really new types of teams. So back to this idea that health systems research is multidisciplinary. So it needs people who are experienced in criminology, in policing, in organizational psychology, and maybe in media studies as well, to be able to understand and appreciate how it is that sometimes everyone knows something's going on, but it doesn't reach scandal proportions, but other events reach the position of scandal and then garner attention and action. So it's an area that's really rife for new work. I just want to draw your attention to these two publications who come from colleagues of mine in the UK and in Nigeria through a FCDO-funded consortium led by SOAS, the School of Oriental and African Studies, that really is actually led by political scientists, but includes health as one of the sectors. Ooh. Okay. A second area I want to talk about in terms of the health system is the area of taxation of unhealthy goods. So we know that unhealthy consumption can have a heavy toll on health, but sometimes the interventions to address unhealthy consumption lie in systems outside the health system. And so the idea of taxing unhealthy goods comes from the really simple observation, my left-hand diagram of a demand curve. So as prices increase, people will tend to demand less of them. And so taxes work partly by raising the price for consumers and reducing consumption of these unhealthy goods, but they can also be used to incentivize producers as well. So the way that some taxes on sugar-sweetened beverages work is that the tax rate is higher on drinks that have a higher sugar content. And so what that does is encourage producers to reformulate and reduce the sugar content of their drinks. And so sugar-sweetened beverage taxes have been introduced in South Africa. They've also been introduced in Mexico. And this is just a little bit of data from a health worker cohort. So it's an observational study. It's only associational. But it looks for different categories of sugar content increasing from right to left, left to right, left to right, how the introduction of the tax has been accompanied by an increase in the no and low sugar drinks and a decrease in the consumption of medium and high sugar drinks. One of the interesting consequences of intervening in this industry, though, is that it raises lots of political pressure. And so managing political actors and understanding the influence of political actors on taxation, and by political actors, I mean big industry, who take a role in influencing politicians. And this is, that sort of influence is the sort of thing that health system researchers need to be aware of as well. A further example of health systems research, I was thinking here about digital technologies, because that's one of the big changes we've seen over recent years. That not only are technologies there to help consumers, all these apps that allow access to healthy advice, or sometimes actually to GPs online, but also technologies that are available to help providers engage more effectively with things like clinical guidelines. And there is a ton of hype about digital technologies. I would say it's a varied and heterogeneous group of interventions, and I think many of them are unproven and also proving challenging to regulate. But this, I thought, was a nice example of how health systems can be used to demonstrate why interventions, in this case a digital intervention to support health workers with quality of maternal and neonatal care in Ghana, sometimes don't work. So this is an intervention that provided mobile phones and SIM cards to individuals or teams to enable them to get advice to improve quality of care and to adhere to protocols. And these phones were enabled to provide phone access, internet access, SMS access, and this thing called USSD, which seemed to be a kind of a simplified way of accessing protocols. And this is over 6 months or so of used the different capabilities differentially. So they used the phone way more and data way more than they used text and this USSD application. Influences on that engagement. So it was really things that went well beyond the health workers, the technology themselves. It was things that were related to the health workers and their characteristics, to the characteristics of the organization, to factors related to clients, and also to the technology itself. But health systems research can be particularly helpful in understanding why things don't work as well as why things do work. And my last example is about e-pharmacy. Again, another digital technology that is becoming much more common both in high-income settings but also in low and low-income settings. And what I mean by e-pharmacy is go to an online pharmacy, order a drug, and have it delivered to you at home. So we had a Wellcome Trust seed grant a number of years ago to kind of explore some of the disruptions in healthcare markets and how regulation was adapting to them. So if you think about e-pharmacy, it's easy to think of the risks, the risks of people getting access to prescription-only medicines such as antibiotics and narcotics without a prescription. Also the risks of falsified medicines, so potentially less control over the supply chain, and also issues of data security. But they might actually offer some advantages as well. So if you think about what the status quo is with many, many small bricks and mortar pharmacies, they're called, the real live pharmacies, it's awfully hard to regulate those, and we know we don't regulate them well. So maybe having larger online pharmacies might be a way of actually strengthening regulation, because it might be easier to regulate a few smaller actors than the multiplicity of mom and pop drugstores. It might also help with traceability of stocks and being able to actually secure supply chains. And there's some technologies, in the use of blockchain, that might actually provide more secure records as well. So it's an area that's got some benefits as well as some risks. But it's definitely a case where tech found that really the regulatory systems were really not fit for purpose. They were not able to effectively regulate. They didn't really know which way to go and even how to regulate it, whether it fell into the e-commerce regulation world or into the health regulation world. This was actually followed on. My colleague Catherine Goodman secured a grant from the Health Systems Research Initiative to explore this further, and particularly to look at things like the quality of medicines and also access to unprescribed drugs through the e-pharmacy approach. So my last slide then is really about the remaining challenges. So the first I would say is who asks the questions. So we know that health policy and systems research is by its nature an applied field. So it should be addressing the policy and the implementation issues that are driven by policymakers and program managers. But often the questions are really driven by researchers and by northern funders. So we need much better models of collaboration and much better ways of working with policymakers to hear their questions and to formulate them. It's not easy. I think often our engagement with policymakers is around problems rather than questions. So it's an area that really needs a degree of dialogue and patient communication. A second issue is about funding. The funding for new technology far outpaces the funding for health systems research. So this is an old figure now, but I'm not sure that it would have changed very much, where kind of most of the health gains are driven by applying existing technologies, yet most of the funding is to develop new ones. So this is important, I think, for research funders, but I think what's particularly important is to think about sources of domestic research funding for health systems research, because that will both increase the pool of funding, but also increase the power of policymakers to make sure that questions that they need answering get addressed. A third issue is complexity. Health systems interventions are always complex interventions in the sense that they work at multiple levels and they change as you evaluate them. So good questions about when's the right point to evaluate and at what point do you lock something down to complete a full impact evaluation. We found the MRC complex intervention guidelines really helpful, but also implementation research guidelines helpful. Influencing policy and practice is my penultimate point. So there is actually quite a lot of knowledge about how best to use research to influence policy and practice. And this has to do with structures that embed evidence into policy-making strategies and practices, that support demand-driven research, that strengthen the capacity of research users to use evidence, and that provide better, more accessible, more useful syntheses of existing knowledge. And finally, this issue of generalizability. Health systems are contextual. They are very influenced by place. And that's actually a barrier to transferability of results from one setting to another. So I think that what's really critical here is that we continue to see health systems as a comparative science that often involves testing things in different contexts. So to conclude, let me say that I heard yesterday and today some fabulous accounts of excellent science. But I would challenge you to recognize that that excellent science is only going to have impact if we understand the systems through which that science is delivered. And that means making sure that there's secure and stable funding for health systems research, but also that we nurture and support and develop health systems research capacity. Thank you.
Thank you very much, Professor Hansen, for delivering this important message. and also for sticking to time. Thank you. So our next speaker is Dr. Melissa Martinez-Alvarez, who is the head of the Social Science Program at the Medical Research Council unit here. Melissa is based in Dakar, and she also holds a dual appointment with the, I hope I pronounced it well, Université Cheikh Anta Diop. Okay, thank you. Melissa is also the PI of a research project on health systems, and prior to joining MRC in 2018, Melissa was based at the Faculty of Public Health and Policy at LSHTM for 10 years, where she's also worked in Tanzania, Malawi, India, and China. And Melissa is supported by a wonderful social science theme that you'll be hearing about shortly as soon as the slides are loaded. Perfect.
Thank you.
Thank you, Melissa.
Thank you so much, Julie, for the kind words. And whilst we wait, I just want to thank the organizers for all the hard work in making this symposium a success, as well as all the platforms at the unit who have worked so tirelessly. Thank you very much. I'm going to start my talk by being brave and saying something in Wolof. Gor, Bachna, Jigen, Bachna, which means men are good and women are also good. And today, I think we have the privilege of being in a day where we have had a lot of parity. And I'd like to acknowledge all the women who work at the MRC unit in the Gambia, because they are all really brilliant, and I have a lot of admiration for them. So I just want to pay tribute to all of them. Thank you. Okay, so now for the science. So I have the very difficult task of to give a 20-minute overview of all the social science work that is currently taking place at the unit. So what I'm going to do is start by giving a sort of very brief overview of all the work, and then I will sort of dive into a couple of project examples or thematic areas. So the trajectory of the social science at the unit, it started way before I joined the unit in 2018, and I think that all of the social science work happened as work packages in larger grants, and it was mostly led by external partners, Julie being a key one, but also Koen Peters and others at ITM. And the trajectory is now we are moving towards purely social science projects led by unit researchers, but also working in larger projects, leading social science work packages, but using these to contribute to our overall program of work on social sciences. And we're sort of somewhere in between these two boxes at the moment. So this is social science unit in numbers. So we have social scientists in each of the three themes attached to projects. Sorry, this is an old slide. There are 3 in DCE, not 2. 3 in VIT, 1 in nutrition and planetary health. And then there is the team that I lead, which sits in the West Africa platform. So we are cross-theme. We are 10 social scientists, and we do purely social science projects. So we have a total of 17 social scientists in the unit, and overwhelming 40 projects over the last 5 years. So I'm really proud to present this, and I am presenting the work of 17 colleagues plus all the external collaborators. So the strategy for the social science, as I've just mentioned, I'm based in the West Africa theme, and I'm physically based in Dakar. So we have a regional approach to social science at the moment, Senegal and the Gambia, and I'm very keen to keep building on this south-to-south collaboration. The advantage of being based in Dakar, I'm based at the Université Cheikh Anta Diop and also at IRSF, and the advantage is that we have really fantastic colleagues with many, many years experience on social science. So what we're trying to do is to link the sort of junior and less junior postdoctoral research scientists in the Gambia to the sort of professors based in Senegal. We are also, of course, collaborating with northern institutions, both European and North American universities, And we work in very close collaboration with the Ministries of Health, both here in the Gambia and in Senegal, and also with civil society, both here in the Gambia and in Senegal. And I find these collaborations with civil society really fantastic, because they're very much on the ground, embedded in the health system and in the communities. So we actually do work across most social science disciplines. So here, they're in alphabetical order, so no favorites. We have anthropology, demography, economics, history, political science, social epidemiology, and sociology. We also have work at the unit across all methods, so from advanced statistical methods and econometrics, all the way to geospatial analysis, more descriptive quantitative work, qualitative work in terms of interviews, focus group discussions, but we're now also exploring participatory research and the co-creation of data, which Cara mentioned earlier. And this is an exciting area of new research that we are doing at the unit. The research topics in which social science takes place is actually very, very broad. So I've categorized them into 7 main thematic groups. So we have sort of systems and implementation research. So we have a large body of work on health systems work. There is some work on evaluation. There has been quite a lot of work on economic evaluation. And there is starting to be some work on process evaluations. There is some work on community engagement, and I'm very excited to continue the discussions with Deborah and see how we can link up with the fantastic work that they're doing in Malawi. There is, of course, a lot of work on infectious diseases, COVID and other emerging infections, malaria, hepatitis, TB and other respiratory infections, as well as work in non-communicable diseases, hypertension, nutrition, fractures, mental health. There is a large body of work on vaccines, which the team this morning already presented on, looking at barriers and facilitators to vaccine uptake and also vaccine acceptance, which is really crucial. We do work across all population groups, so sexual and reproductive health, maternal and newborn health, child health, adolescent health, and aging. And we have social and structural determinants of health, so there is work on migration, which I'll talk to a little bit about, religion and family structure, as well as budding program of social science within climate change and planetary health. And finally, there's a body of work on perceptions and beliefs, so more anthropological work on the understanding of health and disease, but also understanding health-related behaviors. So that's the sort of overview, and I'm now going to talk to you about the first highlight, which I'm a health systems researcher, so it's on health systems. So I will present to you a different framework to those that Cara presented, and I am using the framework just sort of to organize ideas and to organize projects. But this is essentially the WHO framework on the 6 building blocks. So we have governance, information, financing, service delivery, human resources, and medicines and technologies. And what I like about this framework is that it acknowledges that they're all interlinked, and they have people at the center, and people are the patients, the community, also the health workers. So I'm going to talk, we do research on all of them, but I will talk to you about 3 particularly. So service delivery, we have done some work on quality of care, and all of this work has been around maternal and newborn health, both in Senegal and in the Gambia. And I have an example here of some work we did with Francesca Cavallaro, who used to be at the school, looking at the readiness for emergency obstetric care and referral in Senegal. And we published this in the BMJ Global Health. And we found that only around 16% of all public sector births in Senegal actually occur in facilities that provide minimum safe childbirth conditions. So this has sort of led on to other projects where we try to understand a bit more what is driving this. There is a body of work in which I'm not involved, looking at introductions of new products and services. So there's some really exciting work looking at the integration of digital diagnostics, which Cara also mentioned, into healthcare and policy and practice. And this is led by Professor Cunnington from Imperial, but Julie from Sheffield is also leading the health systems work package. And there is some really nice work on infertility care in the Gambia, which is led by Susan Diedrichs from ITM, as well as Julie. And we have a new project that's just beginning, looking at health systems adaptation to migration. And here we're looking at Senegal and the Gambia. and we have social scientists in both sides. And the idea of this is to work with policymakers to develop a health system strategy to coordinate both of their health systems to take into account population mobility. And then we have a large program of work around health financing for universal health coverage. And this takes place in different countries in Africa, not just West Africa. So, of course, the Gambia and Senegal, but also Nigeria, Tanzania, and Zambia. And this is part of a collaboration with the health financing team at the LSHTM, led by Professor Joe Borghi. So I have another framework, but I promise you I will not explain it. I just want to show you that this was developed by Joseph Kutzin, who's the chief health economist at the WHO, to highlight how health financing can contribute to universal health coverage goals. And I have marked a star to show where our projects lie within this framework. So we're covering the different health financing arrangements, how resources are raised, pooled, and used to purchase health services, as well as the universal healthcare intermediate objectives, equity, efficiency, and transparency. And then we are looking at 2 of the 3 universal health coverage goals in terms of utilization relative to need. And of course, we look at financial need and universal financial protection. And I also want to say we're developing some exciting new methods about how to assess financing for specific population groups and health priorities. And we've just applied to the ESRC to do some secondary data analysis to see if we can improve on this framework. So fingers crossed. And then finally, people. So the demand side of health systems, there are many, many projects here. I'm just going to highlight 4. So with my team in Senegal, we have a project with adolescents, looking at the barriers to service use for sexual and reproductive health. And we're using crowdsourcing, which is quite a novel participatory research method. There is the PRECISE project, which is Precise on Diet, which are happening in Farafenni in the Gambia. And there is a work package there on health systems led by Brahima Diallo. And he's looking at barriers to accessing quality maternal health care in the Gambia. And I should mention my 2 colleagues, Ndeya Correa and Maimouna Diédiou, who are working on the crowdsourcing. And then there is work led by Sheffield, by Shami, on barriers and facilitators to implementation and uptake of inhaled medicines for chronic respiratory conditions in the Gambia. And of course, a lot of work on malaria and anthropology of malaria. And I've just led mostly by Koen Peters. And I've just put one example here of adherence to anti-malarial treatment during pregnancy in the Gambia. And my second highlight is the work we've done on COVID. So Anna talked a lot about the work the unit has done on COVID. And I'm just going to amplify a bit what we've done in terms of the social science. So the topics that we covered were community perceptions and attitudes towards the virus itself, towards the response, including quarantine, social distancing and masks and vaccines, towards the health system and any sort of differences in care-seeking behavior or perceptions of health workers, etc. And then perceptions to research itself, so to the unit doing research on COVID in the community. And we took 2 different approaches to this. Together with the data team, we developed an information tracking app. And tell us where the information was coming from and the content, etc. So we would analyze this, and Lamin Lee was really very active behind the scenes. And we would produce a weekly report for the unit's communication team, for the unit platform on COVID, and also to the Ministry of Health to inform them, of any misconceptions that were circulating. But we're a research institution, so we also did some research projects. So Hadi Allen worked with me and Julie to lead a rapid assessment of COVID perceptions in 3 sites in the Gambia, in Serekunda, Keneba, and Farafenni. Anna talked about the research as part of PATS, led by Brahima Diallo and myself, on the perceptions of barriers to participating in a COVID trial. Penda Jom, Tosin and Beata, who I think is somewhere, have done a lot of work around knowledge and experiences of individuals in mandatory institutional quarantine in the Gambia. And then the Zero COVID project that Anna also presented yesterday has a sort of social science component looking at health-seeking behavior during COVID-19, particularly amongst the groups where the team have observed that there has been excess mortality, so under one and the elderly. And I am on my almost last slide. So I just wanted to almost end by looking at the future. So the MRC unit is obviously a regional center of excellence on biomedical research. They have been here, we have been here for 75 years. We're much younger. We're not 75 years old. So I think our strategy, I'm summarizing again, for the work to be led by scientists in the unit in collaboration with our partners, to have a large program of work on social science, and to continue participating in biomedical projects where we support the work they do as well as answer our own research questions. And demand far, far, far outstrips our ability to produce work in each of the to continue to strengthen our disciplinary and theoretical focus as well as our methodological expertise. And once we're at the top of our disciplines, we should be driving innovation. So, as I've said, we should continue supporting the unit as well as developing our own agenda. And I'm very keen that we continue to maintain to South collaborations that are already taking place between Senegal and the Gambia, and to extend this into East Africa and South Africa. And I want to continue talking to our colleague, Deborah, stronger relationships with our colleagues in the University of the Gambia. So I actually have 2 acknowledgement slides, but I will go through them quickly. So I want to thank all the PIs who have had an interest in social science, because none of this would have been possible without them. I want to thank the unit leadership for believing in social science and investing in it. I really want to thank the funders. So I've got here the funders who are currently or previously funding our projects. But just more generally, I think the funders have really insisted that projects have social science components to them, and this has really driven the sort of perceived need for social science, and it has really helped us establish ourselves. I want to thank the training department, because none of the work I have done would have been possible without them. So thank you, Hassan, and everyone. The West Africa platform has also been instrumental, particularly Dembo Kante and Martin Antonio to facilitating my presence in Dakar. And then all our external collaborators and partners, and most importantly, all the social scientists in the unit. I am always so pleased to see so much energy, so much drive, so much willingness. Sometimes the energy is overwhelming, but it's really fantastic. So really thank you to all, both in Dakar and here. And just my final slide, these are a sample of all the people that actually need to be thanked, both at the unit, at the school, our collaborators in Senegal, and our collaborators across the world. Thank you.
Thank you so much, Melissa, for that excellent overview. I would also just, if I may, use my chair's privileges to acknowledge Anna Aferi, who is in the audience online and who's been leading the fertility care work as part of her PhD. So thank you, Anna. So our next speaker is Dr. Boubacar Ba, who is an associate professor and head of data science here at the unit.
Yeah.
He's head of the Data Science Research Group at the African Institute for Mathematical Sciences in South Africa, and also holds the German Research Chair in Mathematics and Data Science, and computational mathematics, an MSc in Mathematical Modeling and Scientific Computing, and a BSc in Mathematics and Physics. And I think that's wonderful presentation.
All right. I have a few comments to make. First, I thank the organizers for inviting me. This has been a very wonderful organization behind this successful meeting. I congratulate MRC also for being 75 years in the Gambia and doing very impactful work in health research. Yeah, as you can tell from the introduction, I feel like an outsider to this community, right? Yes. in two ways. Firstly, I just started working with MRC in January, but also my background is a bit far away from most of you in this hall. So I will therefore make a disclaimer. Some of the talk I'm going to talk about a few things that would involve health. So if you feel that I'm off, please let me know after the talk, okay? And then the other thing I want to say is I'm super impressed by the talks I have had since yesterday, since day before yesterday when we started the symposium. And I'm very encouraged by the amount of data that is being involved in a lot of these talks. So this is what a data science center needs, and we think we should be able to do very cool data science stuff working with all of you. All right, so let's get started. So I was given the task to talk about applications of AI or data science to healthcare. And so that would be the outline of my talk. I'll just put things into context a bit, talk about healthcare and justify why you want to use AI for healthcare, and give a bit of a background on AI, talk about opportunities of applying AI and some challenges in the applications of these methods. Okay, so in my introduction, that's what I will be talking about. So this was some results that I found on the John Hopkins, some of the research they do. So this thing this is showing that there are some issues with our healthcare. So they claim that 30% of care adds no value, or it's full-time, okay? The 30% of care that we give currently, or 45% misses the necessary interventions, or 1/3 is just full of medical errors, okay? So how do we fix this, okay? So the claim is that healthcare is in trouble, there's a lot of inefficiency, there is shortages, and there are medical errors. How do we fix that, okay? Then there's another problem, and this I can see or I can feel from most of the talks that were made during these few days. There is an increase in chronic diseases. And this increases the burden on healthcare and it impacts on patients' life. Another claim is that more than 45% of people in the US will develop cardiovascular diseases in the next 15 years. This was in 2019, I suppose. Greater than 86% of healthcare costs relates to chronic diseases. So what about in Africa? The WHO claims that rising of chronic diseases in Africa is the leading cause of premature death. Of course, we have seen this in some of the talks also, okay? Wouldn't it be nice that we can predict the future? We can tell people what to do to avoid having problems in the future. And we think AI might help us do this. You know, can we do things like early detection of diseases? Can we inject more accuracy in the decisions that we make? We decrease malpractices and fraud, workflow automation, we optimize processes and systems. These are places that we can apply AI algorithms in. Okay, so let me try to give you a basic crash course in AI or data science. So the first category of AI, which was there ages ago, was this expert systems where you have, so X is just a data. So you have some data, an expert sits and writes the instructions that whatever system you are building will follow, okay? So remember, the goal of AI is to build an intelligent system, okay? It could be a computer, it could be your phone, it could be on some of the devices you use in your medical experiments, okay? So somebody writes instructions like, let's say Abdul does some genomic sequencing, and automatically the instructions tells it where to store the data and what to visualize out of the data and so on, okay? This is an expert system, so it means an expert has to be involved in doing that. But recently, most of the success recently in AI is taking the expert out of the loop. Okay, and this is what machine learning is doing, okay? What you do is you want the system you're developing to learn from the data, okay? So let's say X is your data and you have labels, okay? The system now takes the input as X and knows the label, so it looks at many, many examples of inputs and outputs, and eventually it's able to, we would call it an algorithm, whatever name you want to call it, okay? That's machine learning, no expert involved in that case, okay? Of course, a new version of machine learning, a new branch of machine learning, which is mostly used for gaming, is this the reinforcement learning. I just wanted to mention it here for completeness. It's not being applied much in the health care, but it's important to know that. So in this talk, I'll be using terms like machine learning, deep learning, data science, AI. For all intents and purposes, you can use them interchangeably, okay? There are subtle differences that wouldn't matter to us in this audience, I guess, okay? So what about data science? I guess all of you are data scientists. All of you present things that involve data, right? So basic statistics that we do, okay? So it just think of it as being statistics and machine learning, okay? And machine learning also involves, you can see it has an overlap with statistics, involved with more computation. The data is much larger and so on. To do this, you need some computing skills, but you need a domain expert, to be able to understand what the outputs you're getting from this. Okay. Then I'll talk about a few success stories, probably most of you in this audience are aware of. So machine learning or AI or data science is an active research in the area of developing self-driving cars. And I think in some controlled environments, this has been a success. Some of us are involved with is machine translation or using some of these machine language kind of tool at the background, okay? These have been very successful recently. And reinforcement learning I talked about was used in this AlphaZero game. AlphaGo is a game that was very difficult for computer scientists to develop algorithms to win human players until recently when they developed this one that uses the reinforcement learning. And this was in, I'm not sure which year was it, I think it's 2019 when they won the champion, the machine learning algorithm won the champion. Okay, so these are nice tools, they're getting nice things. How do we use them more usefully so that it reaches everybody? And this is, health is in one of those areas where we can reap the benefit of these tools, okay? So applications of AI in healthcare can be thought of in 3 different ways, okay? We can apply them in medical diagnostics, we can apply them in, I'm gonna give a couple of examples in each. MRC data, that's electronic medical records data, to do things like medical imaging and diagnostics. We can identify patients at risk, we can determine main risk factors, we can monitor or analyze disease progression, we can do things very close to what the social scientists are interested in, like predicting hospital readmissions, heart failure, and so on, okay? There are a lot of things that you can use machine learning for, or AI or data science for, in using data from our electronic medical records. Now I'll give an example in diagnostics. 3 to 5% of radiology reports contain, to be the case, we can detect very tiny trauma and small fractures using machine learning much more efficiently than humans, from using machines, okay, than humans, okay? So we outperform humans in reading radiology scans or retinal imaging to assess eye conditions, identifying tumors and tracking cancer spread, flag abnormal potassium levels, and so on. So these are different companies that have developed tools for this, like Imagine developed this reading radiology scans algorithm or tool that is much more accurate than humans. Google's DeepMind worked on these retinal images. Artery and Mayo Clinic also did those works, okay? So AI will help us increase the accuracy in diagnosis for our medical actions. I give a use case that we were involved in, and this is about diabetic retinopathy. I had a discussion with Job yesterday about retinopathy. The idea of predicting diseases from the images of the retina, okay? The preliminary work was done by Google DeepMind, I mentioned in the previous slide. And what we did was, how do we improve this, but also add attention? Where was the model focusing on the image to decide that this was a diseased image or a non-diseased image, okay? And so in them, so that they could identify regions where the algorithm was looking to classify a particular image, okay? The other one, okay, let's see if this works. This is, again, I'm just going to give a quick background. This was actually after visiting MRC in 2019 when we had this workshop on AI in health. And so we were trying to find collaboration with some of the researchers, and we wanted to do a proof of concept of how do you do TB diagnosis using machine learning or AI. Let's see, it's working, okay. So this was in collaboration with Abibulai, who is works at Air Liquide in Paris. He's working on developing algorithms for AI interventions. And we had this MRC student doing this with Mohammed. Okay, so there was a demo. What you would do then, we train our model, and we're just trying to see how we want to deploy it. You would pick an image from your database, upload it, and hit upload, and it would tell you whether that was a TB image or not. So results, in this case, for instance, it says TB is positive, and it gives you the probability of which, of its classification. I don't want to go more than that, just let's move on. Okay. Another project, what's happening? Okay, good. Another project I was involved in is doing AI for malaria. Again, these are numbers that most of you are familiar with. This is the malaria burden thing. And what you typically would do a blood smear and do some microscopic visualization. There are issues with these traditional methods. This is there are resource constraints. There is time needed, and there are delays. Diagnosis, accuracy, and cost are all issues. So the NIH has a malaria data set with these swipes in pictures and images, like 27,000 of them. You can train an AI model on those images. Okay, those are examples of the images, uninfected and infected, because you want to show the image, the model, what images are based computer vision for malaria diagnosis. And it has an error, the level of 3%. And we think this is better than what humans typically would do. But even if it's not better, this would help where we don't have the right personnel to do the analysis, right? So the second area where we can apply AI and data science is risk prediction and prevention. Okay, we talked about the issue of chronic diseases. So one way you want to do this is use telemedicine, for instance, okay? You want to do risk classification and then patient selection, identify patients that would come to hospital and patients that would stay home, and also use some AI actually to support home care programs. And then you can predict the hospital readmissions and risk predictions, and all that could be done. Reduce hospital readmission and do risk prediction. I think I will skip that. We know this is, people can look it up. These are all examples of telemedicine. I think I'm going way below time. The other area would be using drugs, for recommending drugs. You know, we have a lot of examples of data where drugs have been used and patients' outcomes are known. Then you train a model that would therefore recommend drugs, and this could be improved much better actually with genomics. We have extra markers or characteristics of patients that we can use to tailor certain medication towards the patients, okay? But this is not without challenges, so it's important as a community we know that there are challenges that we should be aware of. We can categorize into three: organizations and the processes, okay? The data is, we have few clinical databases, and the quality of this data to go around this data, okay? The weak incentives for sharing data, and this is something definitely we should talk about as a community, given that we are interested in using data science and AI, because without data, the methods we currently have won't work, okay? There are privacy concerns, of course. In terms of algorithms, there is lack of transparency. Most of these algorithms are black boxes, which is not convincing to most practitioners in this community. The organizations have to have clear strategies how to transform and digitalize healthcare system. Some advice on how to overcome those challenges. We should have a clear strategy for sourcing data to enable AI to work, we avoid the silos. We get talented people with appropriate skill to set AI to work, and leadership should be committed to get people in this space. AI solutions with care professionals, we involve the care professionals in developing these tools, okay? In terms of precision medicine, we should be aware that most of the guidelines are based on average behavior, and we can tailor things down to personalized medicine because we understand that each individual is different, okay? So, of course, the average behavior may be representative, but you may have more impact if you can tailor it down to individuals, okay, to capture the variability in the patients. One big challenge that I needed to highlight was the data privacy. This is a big problem, okay? So, but how do we prevent patient risks? There are key things that we should be aware of. There's personal information that we should find ways to anonymize so that we keep people's information private. As confidentiality issues, we have to abide by rules like the GDPR. When data is not intended for sharing, we should find a way to securely host it that people will not have access to it, okay? So in essence, I'll summarize in one slide. AI is supposed to help us augment intelligence in this healthcare decisions that we make, okay? So essentially, that's what it's supposed to do. And I like this quote by Rand. He says, health systems will not be replaced by algorithms, okay? And I think sometimes the phobia from our practitioners is this, like, am I going to be replaced by an algorithm to do my job? No, we are not going to be replaced by algorithms. But health systems that do not use algorithms will be replaced by those that do, okay? So we should think about algorithms and how do we embed these algorithms to make our work more efficient and, in fact, better, you know, where we have errors and we can improve those errors using these algorithms. Why not we do it? So if we know areas where the machines can do better than us, let them do that, and we do other stuff that we can do as humans much better than the machines. Thank you very much.
Thank you, Dr. Van. Thank you also for sticking to time. Wonderful. So thank you to all three presenters for, I think, a really engaging and fantastic presentations. We've got half an hour for the Q&A, and I would like to start with a message that's come in on the app from Ms. Jawara, who says, thanks the organizers for inviting all the students, and thanks also the attendees for all their inspiration. So Ms. Jawara says, before the symposium, she was looking forward to becoming a clinician. But getting to know about these great scientists and their beautiful work, she's been really inspired. And so her question is, what advice will panel members give to students, medical students, who are now thinking of becoming clinical or social or data scientists or health systems researchers? Thank you for the question. And I think it's open to any of you. So, yeah. Who would like to go first? Thank you. So, yeah, you click that one.
Okay, cool. All right, thank you for your question. It's a very interesting question. And I think in terms of data science, this is very interesting. And I have interacted with a couple of people. I actually work with a couple of people who actually have medical science training background. You know, they had a medical degree, and they decide they want to go and do a master's in data science or PhD in data science. You know, and you find that this is when I discuss the composition of a data scientist, having some mathematical skills, having some coding skills, and then having some domain knowledge. So this is a guy who already have the domain knowledge, and now they are going to learn the data science skills. So they might be a better data scientist than the data scientist coming from computer science or mathematics. So I think, yes, if you think you want to be a data scientist, after a medical degree, you can certainly go on and become a very good data scientist. Yes.
And I think the same is exactly true about those who want to be health systems researchers. So having some domain knowledge is really important because health systems isn't a discipline, it's an application. So you can bring all kinds of domain knowledge to that set of applications. So I think clinicians are great health systems researchers because they have the understanding of the health system and are also familiar at first hand with the sorts of challenges that exist. So again, starting with the domain knowledge and then adding to that further postgraduate training in health systems is a great way to build that career.
And if I can add a controversial note, I think your health system also really needs you as a clinician. So my advice would be maybe don't completely leave it, but try to combine a career in research with clinical service.
Thank you very much. So I hope that's been inspiring. We'll go to the lady in the middle and then to the back.
Hi, this is Bouke de Jong from Antwerp, and thank you all for really nice and provocative presentations. I have a question for Cara on this issue of corruption in healthcare systems. A flip side of that coin is the perverse incentives that are in many areas apply, and I work on tuberculosis, so if we say we want to find the 3 missing millions, and in Geneva we say, this is a nice goal, but it translates 20 levels down to next year you find 100 patients, otherwise you lose your job. Then we seasoned epidemiologists say, yeah, we know that these numbers are fake. And in a clinical trial, we actually encountered consecutive patients with the same genotype and then did additional molecular analyses, and in 2 out of 8 clinics, they had succumbed to the pressure from the principal recipient to essentially split sputum and start 3 extra patients on treatment who didn't need it. So I don't know what the way forward is to encourage doing good work without setting targets, but I see a lot of fallout. So how do you think about those?
So I think actually your question is probably more related to the issue of pay for performance of any type and health outcomes. And we know from systems of pay for performance all over the world that you get what you pay for. So you have to be really careful what you pay for. And there's actually, so I don't think that pay for performance has been widely implemented in the Gambia, but I think of many, many countries across Africa that have implemented pay for performance systems. Often at the encouragement of the World Bank that ran a trust fund for many years to set up pay for performance and evaluated it. And there's quite an interesting report that's come out in the last 6 months from the World Bank that kind of pooled all the data they had on pay for performance. And then a few studies where, so pay for performance was often seen as a way of incentivizing health workers to do something, whether it was quality or whether it was increased coverage. And there's a really salutary lesson in this World Bank report that shows that it did head-to-head comparisons of pay for performance versus just giving the money to the system without attaching a performance target. And actually, in many of the contexts where that head-to-head comparison was run, the direct facility funding was as effective as the pay for performance. And I think, so, and they do quite helpfully kind of wheel back and say, so what's going on here? And the main lesson is understand what the constraint is before you impose a solution. And that, I think, is a really important lesson if we're trying to understand what, why it is that health systems are failing to provide effective, high-quality coverage, is understand the problem first. Because if you go straight in with a solution that's based on a notion of effort, which you're describing, then that may not be what the predominant problem is, and you might cause all kinds of unintended consequences as the one you're describing.
Thank you very much for that brilliant presentation. I have two questions, one for Kara and the other one for Boubacar. I mean, for Kara, I want you to comment a bit more on the conclusion on your slide about funding, and I bet that you agree with me, it's not only for health system strengthening, but also for research in general, because for us to have impact, we need really sustainability in terms of funding. I would like for you to comment on maybe a new model that could be adopted to better fund research in general, because we all agree that the current model is really challenging to obtain lasting impact. So that's my question. I mean, for Boubacar, thank you really very much for opening our eyes with data science. MRC celebrating its 5-year anniversary sits on a lot of data collected over the years. And it also really enjoy that stability that this data collected over the years benefits from some rigorous standard. I would like you to, kind of explain how we can use data science in order to learn more about the data that have been collected over the years by doing some data integration to better understand the pattern of disease. Often we are working with very limited data and drawing a lot of conclusion. I think the ability to do data integration and expecting expertise in terms of data science could make us know more about the elephant holistically. Thank you very much.
Thank you. So you're asking a big question. Could there be a new model for funding? So I'll just speak about two things. One is in terms of national funding. I think national commitments to science and to research are really important. And there are some models around. In Kenya, for example, there was a law that committed 1% of something, GDP, to fund research. And I don't know whether that commitment was ever fully honored, but there's certainly for some years there was a substantial national research fund that really helped to develop the careers of people at different stages of their research development. I think the underlying principle there is he who pays the piper calls the tune. So by having national funders, there's a much greater likelihood that research, at least some research, can focus on locally developed priorities. I think the other thing I would say is that in terms of health systems research, and I think often of health research more generally, there is a change in some of the funders. So the experience in the UK of the National Institutes for Health Research really demanding different partnership models and really demanding demonstration of equitable partnerships, I think, is important. That doesn't necessarily provide more money, but it means that the money is more likely to be used to apply to locally determined priorities.
All right, thank you for your question, Leo. This is true. I think one of the motivations for me joining MRC was this potential to have a lot of data, and probably a lot could be done with this data. Again, the question is, how is this data acquired? How is it stored? And we are planning at the data science cluster how to create a comprehensive data warehouse of the unit, and hopefully then with permission. So you have to remember there are other regulations one have to be aware of, ethics and all that. So we would see if this is possible. Of course, if the more data we have, the more we could probably have a better picture of the problem we are looking at. So definitely, I would implore management at MRC and all the PIs to consider our request when it comes to your desk about giving us access to your data. And probably the question is sometimes people don't want to keep this data, share this data. And what we argue is like, look, your laptop can crash and then you lose the data, right? So we are going to keep it, and we are not going to give it to anybody who is not supposed to have it, okay? We will give you that guarantee, okay? But definitely, I think, yeah, this is a goal of our cluster, and we would work with all PIs to make sure we probably do like secondary analysis of some of the work you have done, some meta-analysis and so on, and probably come up with better outcomes or new results from using integrating different types of data. Yeah.
Thank you. There may be some interesting lessons there from what we've learned about community engagement for how to engage the PIs in terms of their data as well. We're going to take a question online. Thank you. If there's more than one, just choose one, please.
Thank you, Madam Chair. I'm also online, but I'll forgo my question and perhaps choose one that's online. Says from Muhammad Afolabi. Says, thank you very much, Dr. Boubacar Ba, for your brilliant presentation. What is the feasibility of deploying the AI model you described in diagnosing malaria in rural and remote areas in LMICs? Has this been implemented in any LMICs before? What were the findings, and is there any plan for scale-up?
Good question. Thank you. Yes, actually, this data, the one that NIH has, was from Bangladesh. So they collected the samples from Bangladesh, and they can run algorithms to do the diagnosis. And I think it's a collaboration with MIT, so some doctors will take a look at it to confirm. So ideally what you do when you use AI models is that they give you, as you saw the example of the TB scan, the TB diagnosis thing. You give a confidence level, you give the probability of accuracy. And there are some samples where the model will say, I am 95 or 99% sure this is malaria, right? But there are some it will say like 50% or so, So the ones that it's not very sure, then you give to an expert to look at. The one that it is 100% sure it's not malaria or it is malaria, then you can go ahead and give treatment, or he goes and sees a doctor and continues treatment. So it's what we are proposing. So there's a high chance of deploying it anywhere. All we need to be able to have is have the samples taken and pictures of these samples taken. I think they were just using a mobile phone actually to take those samples. So we could take those samples, and we know the mobile phone penetration in Africa is very large, so it should be easy to implement in LMSC countries.
Thank you. And since you had your own question, we would like to hear that as well. Thanks.
Thank you very much, Madam Chair. Thank you very much, Dr. Boubacar Ba, for a brilliant presentation. And thank you for highlighting the reluctance in data sharing as one of the impediments in implementing AI technologies within our environment. As you know, the unit has implemented this data science department in order to adopt novel technologies in our research. What would be your approach in ensuring that the trove of data that we have within the unit and our partners are shared in a very transparent, secured, and controlled manner so that we can benefit from what we have already established as the data science department? Thank you.
Thank you very much for your question. This is very similar to what Leo was just asking. I think we should borrow from this community engagement thing. How do we engage the PIs to convince them that it is in their interest that we have this data? And actually this is a trend now, okay? And the funders are even asking now for people to make their data available, okay? And what you want to run away from is being scooped, right? You're working on something, and somebody put out some data that's publicly available, and they produce results that are similar to what you have seen, but they already got the paper out before you. But why not share with us, and then we work together and write the paper together, and then you are in the publication, right? So there is a lot of benefit of you sharing your data. And again, there would be guarantees that this data is not shared with whoever is not supposed to have access to it, yes. So the right permissions will be put in place. Yeah.
We'll go to the front, sorry, and then we'll go to you. Yeah. Okay, are you happy to wait for your colleague and then we'll come to you?
Okay. Okay, Makar. So for AI, it's an exciting technology, but for the example you give for malaria, you're taking the photos of the smear already. So you're not removing that, you know, that hands-on work on it. You know what I'm saying? So it's like you're just removing, maybe improving the time of the diagnostic, the reading time, so the technician doesn't read the slide. Yeah, so I don't know. Read the slide under the microscope, that's what I'm saying.
Yeah, you don't need somebody to read the slide.
Okay, you're improving the turnaround time, I guess. Well, it's fine, but I have a question around, you know, using AI, using for drugs, administering the drug based on personalized treatment. Hopefully you're going to look at maybe the genetic composition of the individual or epigenetics here and there. In that case, is it possible that the patient has access to the data here? Yeah, it's all about access. And what are the ethical implications for that? And besides, how is the patient going to have access to the data? Let's say the person in the remote village, like Afolabi said, is going to be in a sort of a mobile phone, chip, whatever. Sorry, thank you. Next question.
Thank you. If I understand you correctly, is how are you talking about how the patient is going to be assured that her data is not done in something that he's interested in, or CC has allowed us to do, or is it about the outcomes being communicated to the patient? Okay. Correct. I think
Complexity of it.
I borrowed a word from one of the speakers yesterday about leapfrogging, you know. So there, if you look at this current state of most of our medical care, we are lagging behind a lot, okay? So you would say, how do we definitely implement this in all this setting, okay? But the idea is people are interested in developing tools for low resource settings. And there are models that we are able to run now on mobile phones, for instance, which initially when you're training these, you need high performance computing to train this model, but then you can get a summarized version run on a mobile phone. But again, the outcomes, you know, you can have a device, for instance, you can have a telephone or like an app on your phone that will remind you when to take your medication, for instance. And when it comes to personalized medication, the idea is that you would use the patient's data, but you have other patients and you want to recommend medication based on that. So you may not have genomic data. If you have the genomic data of that person, this would improve actually your predictions. So the more data you have about the patient, the better. But when it comes to access, or when it comes to giving access to other people, this have not only informed consent, but the patient have the right to opt out. If they want to opt out, their data should be removed from, and this is what GDPR also is saying. Yeah.
Thank you. Hopefully we're all familiar with GDPR. If not, you can ask Dr. Barr in the next break. I've been informed...
Thank you. My question is to Kara. You rightly mentioned corruption as a major issue in health systems. It's a major issue in socio-economic development in sub-Saharan Africa, but corruption is a global problem. I've always struggled with the difference between corruption in the way you defined it, which is, you know, benefiting yourself from public resources as an individual, to what we define globally as unfair practices, which actually are more damaging and are potentially corrupt. For example, for an African farmer, they get anywhere around 2% of the value chain of the coffee that they grow. And that is because of the unfair setup in the global trade system. African countries invite global investment, give them lots of latitude and benefits, including tax exemptions. But that is accompanied by capital flight from African countries, by the same companies who are given these benefits to invest. And the most you get out of them is a little bit of tax and employment. And so in the end, you lose a lot of resources that could have been reinvested in health systems. that is rarely defined in the global context as corruption, but is potentially more damaging in many ways than the actual corruption that we're focusing on in our discourse. What's your point of view?
Noor, that's a very difficult question. I wouldn't seek to pose one, but or to suggest a solution. But I think it points to a couple of things. One is one person's unfairness, or one unfairness, maybe another person's corruption. So that's obvious. Those kind of deals that go on will invariably involve all kinds of interests and political actors, and whether that's, I think some of the same issues arise with unhealthy industries and commercial interests in health in general. And so that blurriness of the boundary is it's problematic for research, because to do research on something, you need to define fairly clearly what your terms are. So I think I would just throw that back as a research question and say, well, in the context in which if you're studying, what are you going to define as corruption, rather than suggesting a new definition of corruption. But I think it also points to this, to the multidisciplinary nature of systems research that requires paying attention to those actors. And also, you gave an agricultural example, but in health systems, there's also lots of corporate actors involved that may well be using their advantage to extract surplus from developing and emerging economies. And so bringing political science perspective to study those issues is also a really important part of that health systems research.
Thank you. So I would like to wrap up this wonderful session by thanking our three speakers, and also thanking the hosts and the organizing team, and all those who are listening both in person and online. And I think it's time for lunch. So thanks very much.
Let's try to be back by 2:45, please. We've lost for 45 minutes, and we don't want to have a late closing ceremony. So 2:45.